So good morning, everyone. Welcome to International Weekly Meeting in association with CMAAO COVID edition. We are on 28th of August, 2021, 9:30 a.m. Indian Standard Time. And we have a lot of national medical representatives joining in from various parts of the world. So good evening, good morning, and good afternoon for depending on where you are. It is our efforts to bring a lot of new topics, relevant topics, COVID, non-COVID. A lot of countries are still facing pandemic. Some of them are facing third wave. Malaysia is still struggling. And similarly, India is also at a stage where the cases are stagnant. We have about 45,000 cases reported last day. And Kerala is been covering about 75% cases. So we will cover up this amount, the COVID update after the presentation. But today we have one of the very important topics, which is the need of the hour. I will introduce the topic later. Let me first introduce the person. So we have Dr. Dhananjay Vaidya. He's joining in from the US. So I thank you for him to join in because it's a midnight for him. He's the Associate Professor of Medicine in General Internal Medicine Department at Johns Hopkins University. He studied mechanism of vascular dysfunction and the assessment of cardiovascular risk factor. His special interest is in the difference in the heart between the women and men and the role of sex hormones in the risk of heart disease. Dr. Vaidya holds Bachelor of Medicine, Bachelor of Surgery, MBBS degree from Armed Forces Medical College and PhD from State University in New York. He earned his master's degree of Public Health degree from Johns Hopkins Bloomberg School of Public Health before joining in Johns Hopkins faculty. And today he presents a topic, sex hormones, menopause, and the risk of heart failure with preserved ejection fraction. Over to you, Dr. Jay Vaidya. Thank you for accepting our invitation to present. And I will let you share your slides as well.
So great.
Yeah.
Oh, you also made me a host, so I'm getting these messages about people joining. But okay.
So I will remove. Yeah, I know that's irritating. So I'll give you the share screen thing, and I will remove you as a co-host because it really irritates. Yeah, sometimes.
Let me see if I'm doing the right. Okay, I think this is the correct screen that is being shared. Am I sharing a my PowerPoint slide?
Absolutely, we can see that now.
Okay, excellent. Thank you very much to the CMAAO and the Heart Care Foundation of India for this very kind invitation. It's a great pleasure to be talking to you. I know that my topic is, as you said, my research is in sex hormones, menopause, the risk of heart failure with preserved ejection fraction. I know that this assembly is particularly interested in COVID. So I'm going to have a really short intro with a couple of slides about heart failure in the age of COVID, but I must really I must say that this is not at all my field of research, and I stand to actually gain education by any conversation that is sparked by the 2 or 3 slides that I'm presenting about heart failure and COVID, and then I will go on to the topic of my research, which is broader. It's about sex hormones, menopause, and heart disease. The research is all done before the age of COVID. I mean, the studies were from before the age of COVID. So, just to put a practical definition of this word that I'll be using often, it is HFpEF. HFpEF is heart failure with preserved ejection fraction. And the P is small because there is such a thing as heart failure with reduced ejection fraction. So heart failure with preserved ejection fraction was called preserved because the function of the left ventricular ejection fraction is more than or equal to 50%. So it is, in terms of numbers, it is normal. And yet, patients have signs and symptoms of congestive heart failure. So the heart is not moving as much blood as it's supposed to move. And so those are the signs and symptoms. And practically there should also be some kind of objective evidence of a heart problem, either elevated brain natriuretic peptide (BNP), which is a measurement that is very much related to heart failure. I will mention it again and again. So left atrial enlargement. So the atrium of the heart, it backs up, and it because the ventricle is not pumping enough blood, so the left atrium backs up. There will be mention of this within my research. Diastolic dysfunction, uh, elevated pulmonary capillary wedge pressure, and elevated left ventricular diastolic pressure. So this is a figure from a paper that came out, I think, in the middle of 2020, when people were really concerned about the initial big waves of COVID. And here were a number of cardiologists specializing in heart failure that were looking far ahead into the future and seeing like heart failure is going to be a big problem that is going to interact with the COVID-19 epidemic. I hope you can see my pointer. At that time there was not enough data available, but this is what they came up from our knowledge of how heart failure works and our knowledge at that time of what was important about COVID-19. And one is that there are many shared cardiovascular disease factors. Older age, obesity, metabolic syndrome are all related to heart failure, and they were also related to with worse COVID-19 outcomes. There's a shared inflammatory pathogenesis. Here are a number of blood biomarkers that are either directly inflammatory or markers of inflammation. And both of them would be associated with COVID-19 infection on one hand and cardiac failure, heart failure on the other hand. But once there's an acute COVID infection, there are all of these factors: hypoxemia, acute respiratory distress syndrome, further in acute inflammation happening because of the infection, a hypercoagulable state, and direct viral myocarditis, infiltration of the heart, and that could later get to more heart failure. So at an acute level, there would be more heart failure because they share the same risk factors. In the long term, after COVID, there would be heart failure again. And there's also the long-term illness. If the lungs are damaged, that will also cause the heart to remodel badly, and that will lead to heart failure in the future. So let's see. Since the mid 2020, there is some data that have been published. This is a medium large, 2,500, a little less than 3,000 people. This is a study, a registry study from France, where they studied hospitalized patients, those that had heart failure and those that did not have heart failure. Here, if you just think of heart failure per se, you'll see that those that did not have COVID will cause events. Here are deaths or deaths or intubation, and so there are events in everyone. But if people started off with heart failure, then they had worse event rate. I hope people are aware of this diagram. It's a survival curve. You start off with 100% of the people not having events, and as time goes on, in many days, there are fewer and fewer people. More and more people have events. There are fewer and fewer people that remain surviving without events. Now, so it turns out that the overall hazard ratio, which is another technical term which many of you are aware of. It is a way that risk is assessed in survival analyses, and is so there's 1.41 fold, so 41% more risk of having a death or intubation event in people who had heart failure. But when they split out people who had uh, heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, they found that it was much stronger with people with preserved ejection fraction as compared to reduced ejection fraction. So 61% higher risk, 1.61 fold is 61% higher risk in people with preserved ejection fraction. That tells you that one of the things that the 2020 the paper was talking about is that if you have heart failure, COVID could be worse. Looks like that makes sense. And this is a much smaller study looking at the other side. If you did not have heart failure but have COVID, is heart failure going to happen afterwards? So they looked at this is a smaller study, of course. They looked at 64 people who were hospitalized with COVID, 64 people who were hospitalized without COVID, and they all started with no history of heart failure. And then they measured this HFA-PEF score, which is a mixture of clinical and laboratory findings. So if the score is low, there's a low probability that HFpEF is a problem. If the score is high, there's a high probability that HFpEF is a problem. Found that 25% of the people who were hospitalized with COVID had a high score of high probability of HFpEF. When with same age, same sex people without COVID, far smaller group looked like they had a high probability of COVID. So again, this looks like this two-way relationship. If you have heart failure, worse COVID. If you have COVID, there's a worse chance that you might proceed to heart failure at some point if that's where you're going. My main topic later is going to be about sex hormones, and there is not much data available. We have only 1 year of this tragedy going on, so we don't have a lot of long-term data. We know that men have overall worse outcomes than women, but the rest of them are open questions. So I have mentioned a review from by Haithao and others, and they have raised some open questions that should be studied. One is that menopause in women is a worse inflammatory state, and there is oxidative stress, both of which are problematic in COVID. How do those two things interact? We don't know, for example, if hormone replacement therapy in men and separately in men that there's a completely different biology, how they might affect COVID-19 pathophysiology. We don't know. We know, as far as the data are published, that the association of cardiac biomarkers with outcomes. So if you have worse cardiac biomarkers, there are worse COVID outcomes. That does not differ by sex. So having worse cardiac biomarkers is bad both for men and women. However, older women often have worse to begin with. They start off with worse cardiac biomarkers, especially heart failure related subclinical biomarkers. So we don't know whether women who start off with higher biomarkers are going to have worse COVID outcomes. So this is just my slide, 2 or 3 slides to talk about some of the work that has been published about COVID and heart failure. Again, not my specialty at all, and any conversation that is sparked is going to be educational for me from this group. Going to my topic now, this is broad beyond COVID. Just looking at heart failure with preserved ejection fraction. First, looking at sex, men versus women. How does it differ? And yeah, I work in the United States, so a lot of my data are going to be from the United States. So here is a publication from 2006 that looked back at a few decades, and we have been showing that uh, the fraction of people who had preserved rather than reduced ejection fraction has been increasing for the last few decades. Plotting together those with preserved ejection fraction in the red orange and reduced ejection fraction, you see that the increase is only in the preserved ejection fraction. The reduced ejection fraction people have been sort of flat. I know that it looks slightly reducing, but more or less not changing, at least not increasing. So this is something that people have been knowing that this is a public health issue. And there's a sense that because of the name preserved has this very nice sound, like something good is happening. This is not true in terms of how bad the disease is. So this is another survival curve, also published in 2006, which shows the how which that people start surviving, and as they die, the curve goes down. You see that the preserved ejection, people with preserved ejection fraction versus reduced ejection fraction, a lot of them are not surviving. Within 5 years, there's less than 40% of people surviving. And it's the same whether it's preserved ejection fraction or not. And just to put it in a broad medical field, if you, how about let's compare it to a kind of cancer that kills so many people in within 5 years. And so we can see that if we overlay the data for T4 small cell lung cancer, it sort of overlays. So this is a stage 3B cancer of the of lung cancer. So it's that kind of a rapid decline in survival. Uh, One of the bad things about HFpEF compared to HFrEF, I'm trying to do more and more things to convince you that the P of preserved is not something to be happy about, is that many treatments have been shown to be effective in HEF reduced HFrEF. And so here this was a summary that was published in Circulation in 2011. They looked at many different trials with several different therapies, ACE inhibitors, digitalis, ACE inhibitors, beta blockers. They found, and again, the hazard ratio is, when the hazard ratio is less than 1, it means that the treatment is protective. The dotted line here means that uh, that is a sign of the null hypothesis. No difference between a treated and placebo population, or the so for many trials, they showed that HFrEF, when you treat it, the hazard ratio is clearly protective. So the treatment works. But the same treatments given to HFpEF, all of them, they cross the null, as which means that the treatment is no better than the comparison. So there's that. Just to another thing to show the epidemiology of the disease. Here we have plotted ejection fraction from 0 to 100. So higher and higher ejection fraction, the ventricle is pumping more and more blood as a percentage of its volume. And what percentage of patients? The purple is men. And you see that, sure, both men and women have all kinds of ejection fractions, but the peak for men is with low ejection fraction, and for the peak for women is with high ejection fraction. So it tells that yes, the disease is present both in men and women, but there is some difference. So sex or something to do with differences between men and women, though it's not 100%, it can be modulating this really dangerous disease. Another way to look at it is to look at it in terms of how heart failure is related to age. This is a study published in 2017 about United States data. And as you can imagine, always that as people are older and older, there is a greater prevalence of HFpEF. But you'll see that it is a very steep increase in women. And there's an increase in men as well, which is the purple line, but not as steep. When it comes to HFrEF, men have more of it, but you'll see that both men and women have the same shallow increase with age. Uh, so again, to tell you that sex, being a man or woman, does not make it one way or the other, but it probably modulates this disease. So to summarize, HFpEF is a form of heart failure that is increasing in prevalence. I've shown United States data. HFpEF causes as much morbidity, mortality as HFrEF. HFpEF is refractory to treatment, and HFpEF is more common in women, suggesting that the mechanism may be modulated by sex. So one of the big differences between men and women is that both men and women have the same sex hormones, estrogen, testosterone is present both in men and women, but the quantities are very, very different in men and women. So we decided to look at how that modulates heart failure. So not just heart failure, we look for a broader array of cardiovascular disease and just risk factors even. So this is data from a population-based study called MESA. It is looking at people 45 and older. The women are pretty much all postmenopausal, and we saw the estrogen that is present in postmenopausal women is not coming from the menstrual cycle. It is coming from the adrenal glands. It is a very, very small amount of estrogen. Testosterone is being produced by the adrenal glands as well. But you'll see that there is a difference between what sex hormones do in women and sex hormones do in men when we are looking at waist to hip ratio. So people with large waist to hip ratios have more central adiposity, big waists compared to their hips. So having higher testosterone makes for smaller waist to hip ratio in men. The blue is men, but for women, it's almost going the other way around. Estrogen, this is a different kind of estrogen than the premenopausal estrogen. This postmenopausal is higher. The more the estrogen, the bigger the waist, so more central adiposity. DHEA is a prohormone. It doesn't show that much. And SHBG is sex hormone binding globulin. Sex hormone binding globulin is a protein that carries sex hormones and affects how sex hormones act. And it has many positive effects on the body. And so the more there is of sex hormone binding globulin, there is the less the waist to hip ratio is, both in women and men. So there are other metabolic factors. So if you're looking at diabetes, who has diabetes? So this the graph on the top shows the odds of diabetes. So the odds of diabetes in women, uh, prevalent diabetes. So at the same time as the sex hormones were measured, as the testosterone is higher and higher, there is a greater chance of diabetes in women. As estrogen, it is a very similar thing as we saw with central obesity. As estrogen is higher, there is more diabetes. As DHA, we saw that it was not very strong. And as SHBG is higher, SHBG is protective. So there is less diabetes. Now, that's in women at the same time as measuring the sex hormones. If you look for incident future diabetes after measuring the sex hormone, we also see it's very similar. The higher testosterone, higher estrogen, and lower sex hormone binding globulin will cause development of new diabetes afterwards, even in people who didn't start off with diabetes. In men, just as we saw with the obesity, lower testosterone and higher estradiol is associated with worse impaired fasting glucose and diabetes. Uh, we also looked at the association of sex hormones with the progression of CAC. CAC is coronary artery calcium. I've shown a small picture here of a CT scan at the level of the heart. That's it's a cross section. So you see the rib cage with the heart in the middle, and you can actually see the calcium that is deposited. These are the strong white lines that you can see are calcium that is deposited in the coronary arteries. It is a plaque. And so the more the calcium, the worse the plaque. And when we look at the 10-year increase, we are looking at the ratio. So ratio of 1 means the increase is no increase. But if it is a number that is larger than 1, it's just a 26% increase. So people with more testosterone at baseline, these are all women, postmenopausal women, they have a 26% increase in the amount of calcium deposited in their plaques over 10 years. This diagram shows it. So people with high is the red, and low testosterone people is women. These are postmenopausal women. They start off approximately the same, but as you follow them up over years, the red line shoots up and crosses and becomes a much higher amount of coronary artery calcium. Uh, how does sex hormones, how are they associated with change in left ventricular mass? So left ventricular mass, the left ventricular mass, especially in an aging population, can be a sign that the heart is under stress. It has too much load, so it has to increase in size to pump more blood. And here again, we see, and here's a picture, this is from a pathology study, showing that how thick the heart can get if it has too much load on it. So having more pre-testosterone was associated here. 0 means no change. This is a different kind of analysis. Here, positive means that the size is increasing. So the size was increasing with people who had more, with women who had more testosterone. This is an interesting way to look at it, to see that free testosterone levels versus how much the increase was, and the increase is really not that much for low to medium levels of testosterone. It's mainly at high levels of testosterone that this bad effect is seen. How does sex hormones affect the distensibility of the arteries? Distensibility is a good thing. Distensibility is a supple artery. If an artery is supple, the heart does not have as much of a load to pump against. And what we can see again, so here a negative number is a bad thing. So the distensibility is less, it is less supple. So the more the testosterone in postmenopausal women, the less the distensibility. So the arteries are getting less supple, the heart has to work hard, and the heart has to thicken to work hard. There's a picture of the MRI of the aorta, of the sort of data that is used to measure the suppleness, the distensibility of the aorta. And just to one more thing, this is we also were able to study vascular reactivity, which is a good function, which can it can be studied in the brachial artery, which is very easily studied. Brachial artery does not get atherosclerosis, but we can actually see how well it reacts to a blood pressure cuff being inflated and losing oxygen. How does it react? And if it reacts, that's a good thing. So what again, if it a negative number does not react well, and we know that women, postmenopausal women who have higher levels of testosterone, the brachial artery reacts less. So I'm just saying more and more evidence. There are many different ways to study the vascular. Having more testosterone in postmenopausal women is not healthy for their vasculature. Going now much closer to heart failure, I talked about brain natriuretic peptide in the beginning. Brain natriuretic peptide is it's the name was given a long time ago. It is actually it comes out of the heart. It comes out of a stressed heart. It is on a molecular level. It is a protective mechanism, but the fact that it is being splurged out by the heart is because the heart is under stress. So sometimes I'm going to show many other things which are on a molecular level protective for the heart, but the fact that you find them floating around in the plasma means that the heart is in distress. Again, so having higher amount of testosterone is associated with larger amount of NT-proBNP, which is a lab measure of brain natriuretic peptide. Uh, Estrogens here, interestingly, this is a ratio. So 1 means no change, more than 1 means 16% higher, 5 means 5% lower than no change. So again, uh, now we are looking at how much do CVD events, that is heart attacks, strokes, heart failure, happen based on how much, what the sex hormone levels were. And it turns out that in postmenopausal women having high testosterone, we already showed all of these bad things in terms of imaging. But if you wait, then having high testosterone means there'd be a 14% higher chance of having cardiovascular events. Most of those are coronary artery disease events. But really, it is an interplay between testosterone and estradiol. So the higher the ratio, you will see that it's a stronger association. Cardiovascular disease is 19% more likely for the people with higher ratio. Not only do they have more coronary artery disease, they also have a lot of heart failure. So uh, to summarize all of these, what we have shown is to have more androgens in a postmenopausal woman is associated with more central obesity, worse impaired fasting glucose, more type 2 diabetes, faster progression of atherosclerosis in the coronary arteries, more left ventricular mass, which is increasing because the heart is working against a higher load, lower our aortic distensibility, which means the arteries are less supple and producing that higher load, greater increase in NT-proBNP, again a sign that the heart is trying to protect itself, but it's over producing this thing, so it's going towards failure. And if you wait long enough, greater risk of cardiovascular disease events even. So all of what I presented earlier was about studies we did in postmenopausal women. But one of the biggest changes in sex hormones in women happens with menopause. So how does menopause play with cardiovascular disease risk? And so this is just a, a background. We know that how women have lower heart disease mortality as compared to men of the same age. And the increase in heart disease mortality is later in life, so mostly after menopause. So here are some data again from the US. They are from a nationwide study called the National Health and Nutrition Survey. And what we have here is the percent of the population that had existing cardiovascular disease. The blue is the men and the orange are the women. And for younger women, for younger people, we see that men have more cardiovascular disease than women. But as they age, the women not only catch up, they actually overshoot the men in terms of how many women have cardiovascular disease. So again, it gives us the sense that somewhere between 40 and 60 years of age, there is this overtaking happening. So they develop CVD 7 to 10 years later, but once they develop it quite as much and more. Uh, this is some data from the study, a really nice study called the SWAN study, where they enrolled younger women before menopause and studied them every year so that they knew exactly when menopause took place, and they had measurements before and after menopause for these women. And they found that LDL cholesterol, which is the bad cholesterol, it sort of increases, but there's this kind of a step increase at the same time that they had menopause. Uh, the ApoB, which follows the same track as LDL cholesterol, also has a step increase at the time of menopause. HDL cholesterol, which is a good cholesterol, was looked like it was increasing before menopause, but after menopause it started decreasing. Now, we know that age is itself a danger per se, not just menopause. Many things just keep changing with age, not with menopause. I don't want to make this point that menopause is the answer to everything. There are lots of things that I have mentioned here that don't that just change with age and not with menopause. And yet, I want to show that there are some important things that menopause just puts a step increase and makes them worse for the heart. So to summarize this part, heart disease mortality increases with age, both men and women throughout adulthood. However, the causes of heart disease, how exactly it manifests are different, and there may be changes occurring in the internal milieu that happen, like LDL cholesterol, HDL cholesterol that I showed, that happen at menopause time in women. So now I'm going to try to put all of these topics together: menopause, sex hormones, and HFpEF, heart failure with preserved ejection fraction. And one of the things that helped me put it together was a very nice collaboration that happened in our institution called the Go Red Center for Women's Heart Disease. And we have basic science researchers who can work on animal models and actually look at mechanism. We have clinical researchers doing clinical trials, and we have people like me who are epidemiologists who do observational work. And this is what we came up from our putting our heads together. So we know that HFpEF is a disease of the heart that causes hypertrophy, fibrosis, dysfunction. It's actually a disease of the whole body. There is higher adiposity, skeletal muscle problems. But what is happening at the level of the heart cell is that an enzyme pathway called PKG, protein kinase G, is protective of all of these bad all of these HFpEF pathophysiology. And this is a well-known way of how the PKG pathway works. Nitric oxide synthase synthesizes nitric oxide. It creates cyclic GMP, which then goes to PKG and protects the heart. What is interesting is that inside the cardiac myocyte, there is a whole parallel pathway that also goes to PKG from cyclic GMP, but it comes from the natriuretic peptide receptor. Interestingly, even though parts of the pathway are the same, cyclic GMP is just a molecule. However, the pathways are parallel to each other. They don't interfere with each other. This is because our collaborators were able to show that they could block the two pathways by two different drugs. This pathway is interesting for us with menopause and so forth because the nitric oxide synthesis pathway is triggered by estrogen. This, the large levels of premenopausal estrogen. And as estrogen goes down to that really low level and with different biological effects, this whole pathway becomes less and less relevant, and the protection of the heart against all of these HFpEF pathophysiology is reduced. Okay, so what we decide to look at is if this cyclic GMP is this key molecule in the middle of the heart cell, is it associated with protective effects on the heart? How does that play with sex hormone levels? So this is in an observational study called MESA. Again, all of the people in MESA are 45 years and older, 45 to 85 years. Most of them are postmenopausal. Almost all the women are postmenopausal. Men are that age. So the greater the cyclic GMP, the greater the NT-proBNP. Now that is not very surprising because NT-proBNP is supposed to trigger cyclic GMP formation inside the cell. And I'm going to jump over here. The greater the cyclic GMP, the greater the systolic blood pressure. So again, it is not looking like it is protective, but we are not actually measuring cyclic GMP from inside the heart cell. We are measuring it inside the blood. The fact that there's so much cyclic GMP being regurgitated into the blood means that the heart is under stress. It is reactive. So we see that it's actually more cyclic GMP means worse cardiovascular state. Interestingly, cyclic GMP only in women is also associated with testosterone, sex hormone binding globulin, but not in men. So let's see where this complication takes us. when we look at whether cyclic GMP, this key molecule we thought was should be in the middle of the heart cell, protective. Is it protective when we measure it in the plasma? So when we look at those people with high cyclic GMP versus low cyclic GMP, the top third versus the lowermost third, the chance, the risk of heart HFpEF was 1.82 fold, so 82% higher. This was in a study called ARIC, which I've put the logo here. This is among older people. So everyone was older than 65, followed for 20 years. So lots of people had heart failure. So enough for us to do enough for the statistical models to work. And when you adjust for all kinds of things, you see that it does not, it just remains that cyclic GMP is associated with worse heart HFpEF and total heart failure as well. However, what we see is that when we try to adjust for BNP, we see that the association is much reduced so much that it is no longer statistically significant. So it gives us the sense that cyclic GMP, as it is regurgitated into the blood, is probably not the same thing as the protective cyclic GMP that is inside inside the cell, heart cell, but it is actually just a marker that if there's lots of NT-proBNP, there will just be lots of this regurgitated cyclic GMP. And we actually tested it. We tested it by saying that NT-proBNP, which is a direct marker of cardiac stress, of course, if it is high, the top third versus the bottom third, much stronger. Heart failure, there's almost 3.84 fold increase in the risk of heart failure. And if you adjust for cyclic GMP, nothing changes. So what we were able to tell our basic science colleagues is that even though they have a good mechanistic hypothesis, they were able to show it in their cellular models. When it comes to intact human beings and measuring stuff in the blood, the cyclic GMP in plasma is just a side pathway from proBNP, which is a marker of stress. Any intracellular cyclic GMP that may be protective is not actually detectable in the plasma. So what do we think is happening in free living human beings, so especially in sex differences? Menopausal transition happens in women. They have lower levels of estrogen, higher levels of androgen compared to estrogen. Men don't have anything like that happening at that age. There is greater oxidative stress in postmenopausal women, and that when there's more oxidative stress, nitric oxide cannot act as well. It's actually destroyed by oxygen, by oxidative stress. There are lower cyclic GMP levels inside the cell, but more regurgitated cyclic GMP outside as a reactive. And then this causes the hypertrophy of the heart, which is maladaptive. It is not in the long-term interest of health. And if one waits long enough, that will result in events of HFpEF. So we actually looked at this in a different study called the CARDIA study. The CARDIA study enrolled younger women and followed them for 30 years. So these women were enrolled before their menopause, and then they were followed long after their menopause. There were multiple echo measurements taken, and before and after menopause. So we could. This is just a cartoon. I will show real data in the next slide. We can say how fast any measure in the echo is changing before menopause, and how fast it is changing in that woman or in the average woman after menopause. And if there is a difference, so this, if it had just continued, it had gone along this dotted line. If there is a difference, so does menopause cause changes in the trajectory of how the heart is changing with age? And I mentioned earlier about left atrial volume. So the left atrium is the smaller part of the atrium, and it backs up when the ventricle cannot clear out blood as much as is needed, even though it clears out a percentage of the blood that is supposedly normal. It does not clear out as much as needed, and the left atrium grows big. So what we saw, these are all women uh, that started off young. They had some trajectory of left atrial volume. That's pretty much flat trajectory, I would say, because that is a 95% confidence interval is all over the place. But after their menopause, they had uh, an increase in left atrium, which means that the left atrium is backing up. None of these women had uh, frank overt heart failure, but we can see the direction that the direction is changing towards heart failure in the long term once menopause has happened. And left ventricular mass, which is the reaction to higher stress. It has also changed its trajectory. It is not in these women that don't show frank heart failure. It is not increasing or anything, but it tells you that it has changed its trajectory in a way that it could increase in the future. But even at this stage, it is backing up so that the left atrium is increasing in size to show that it is not doing well. So to summarize, we had this wonderful theory about plasma cyclic GMP. The theory is proved in animal models and cell models, but we don't think that cyclic GMP, even though it might be a mechanistic biomarker, it is not a marker that will be useful in human observational human studies. But higher cyclic GMP is actually a reflection of higher cardiac stress and higher BNP, and so worse heart failure risk. And what we have shown is that menopause per se is related to the change in the trajectory of left ventricular mass and left atrial size that is consistent with higher HFpEF risk. This is my last slide, and I want to thank all of the people at the Johns Hopkins Go-Red for Population Research Core. I used research from all of my colleagues. On one side, these are my colleagues on the faculties, and I've specially put us on one side our wonderful trainees who put their heart into doing many of these studies, and without them, the studies would not have been done. Uh, Thank you very much, and that, that is that for my talk.
Thank you, Dr. Vaidya. Very insightful, very in-depth research, and obviously coming it. So I'll stop the sharing screen. You can.
Okay.
Okay, so our chair is here. I thought you were absent today. Okay, so I'll quickly acknowledge our members over here. We have about 22 participants. So we have Mr. Chong, who is the chair for CMAAO. He is from Singapore Medical Association. We have Dr. Ravi Naidu from Malaysian Medical Association. He's also the immediate past president of CMAAO. Professor Nazmi, first vice president and from CMAAO and president from he's from Pakistan Medical Association. Dr. Elvin from Hong Kong Medical Association is the treasurer for CMAAO. Dr. Pillai from India and World Medical Council. Dr. Salma Kundi, president Pakistan Medical Association. Dr. Angelique, South Africa Medical Association. Dr. Jamal Chaudhary, Bangladesh Medical Association. Dr. Mukti from Nepal Medical Association, Dr. Akhtar Hussain from South Africa Medical Association, Dr. Sajid from Pakistan Medical Association, Dr. Prakash from Nepal Medical Association, Dr. Benito from Philippines Medical Association, Dr. Deborah from Brazil Medical Association, Dr. Marie from Japan Medical Association, Dr. Russell from UNESCO, Australia, Dr. Shashank Joshi from India, Dr. Bukhari from Pakistan, Dr. Monica from USA, Dr. Sanchita from India, IGCP group. So, and then we also have a lot of our friends from other part of the world, including Singapore, Malaysia, and all other areas. So I thank you for joining in, and I thank you, our presenter, for giving us. So we will now have question answers. Let's open it. If you have any questions, and over to Dr. Chong also.
Thank you, Sarab, and thank you, Dr. Vadia, for your wonderful presentation. I mean, HFpEF is a very interesting topic by itself. I just managed a couple of very bad, very elderly HFpEF patients, and unfortunately, they were in their 90s and they both perished, eventually. But it's a very, very challenging problem. And I understand some of the cardiologists even feel that it's not a cardiology problem.
Yes. My colleagues at the center often think of it as more like a whole body disease that affects the heart. So they say it's actually a skeletal muscle and adipose tissue disease that affects the heart. That's an interesting way. That is an interesting and probably appropriate way to look at it.
Yeah,
that is probably why the heart-specific medications that work for reduced ejection fraction don't work for HFpEF.
I found very interesting is that sorry, I'm just asking my questions because I find it very interesting that this HFpEF entity, I find the fluid balance is very critical. The intake output of the fluid because very often when you have very ill patients in hospitals, we don't really watch the IO charts that well. But I found that actually IO is critical to managing these patients, and very often they run into problems because the IO is not properly managed.
That makes a lot of sense. I must just tell you that my work is that of an epidemiologist, and especially most of my work is much earlier at the risk factor stage. And so what you tell me from your clinical experience is basically educational for me. But just to support what you're saying in terms of what the American Heart Association has been communicating with its patients, again, COVID and heart failure they have been asked what you have been talking about, fluid balance. They have actually highlighted that in their communications with patients. And these are patients, of course, who are at home, not hospitalized. Just interesting.
Yeah. The other thing I found very fascinating was that I found that keeping the albumin levels high was very important. So, expensive, but IV albumin, what can I say? So that's what we found in these HFpEF patients. Albumin and strict IO control. That's what we found. And honestly, we found that diuretics were very counterproductive. We found that, for example, I tried not to use too much of the Lasix and all this, furosemide and all that, because I found it very, very counterproductive. Because their fluids were all over the place, and using diuretics was just messing everything up. That's what we found.
It's very valuable.
Quite fascinating. I'd like to open the questions to the floor. Anybody from the floor has any questions for Dr. Vajay? Did I pronounce that correctly, Dr. Vajay?
You did. I actually wanted to ask how to pronounce your name, because I tried the internet and I was like, well, I could get the Mandarin for it, but not the Singaporean for it. So there you go.
Vajay. Any questions from the floor?
Dr. Pillai, it's a very interesting presentation and gives a lot of information. The intervention, that is what should be more interested. Does exercise have a role in reducing this eventuality? And is there any drug intervention for this?
So the drug intervention, unfortunately, has been uniformly bad news. Long-term, earlier, now we are talking of exercise, like Dr. Chong said, it is a whole body disease, and skeletal muscle and adipocytes are involved. So at an early stage, at the kind of time that I'm studying that, at the risk factor stage, yes, exercise would be very important. If it comes to people with frank heart failure, I would ask clinicians to comment about how exercise is used in people who are already in frank failure.
Thank you.
Any other questions from the floor for this fascinating disease entity? Is there any change? I'm just curious. Is there any change in the recommendations? I mean, for menopause and hormone replacement therapy. Is there any, or is the everybody still looks at that famous study, that what do you call it? The Women's Health Initiative.
Women's Health Initiative.
Yeah.
That is still the law of the land, because that is the gold standard of a randomized clinical trial, and all the initial hype or optimism, I would say, because everyone wants good things to happen, was coming from observational studies from nurses. And what makes at a time when hormone replacement therapy was not routinely given, the kind of internal motivation that makes a woman go and seek medical therapy and say, I want this, was the sort of thing that probably did all kinds of good things health-wise. So now, people do say a couple of things, that the kind of estrogen that was used in the WHI, the CEE, may not be the appropriate one, and so forth. But I don't think anyone is getting ready to do a new trial. Another thing that I think gets lost in the facts is that that the reason why hormone replacement therapy might be useful in many women is for perimenopausal symptoms. And no one actually said that the Women's Health Initiative never tried to say that it wasn't good for perimenopausal symptoms. If it works for perimenopausal symptoms, what it only says is that if it is not for perimenopausal symptoms, if you're trying to protect from long-term heart disease, it's probably going to be counterproductive. So that's the thing. I think we more or less are trying to look at menopause as an educational moment, and like if you have been unaware of risk factors, reduction, exercise this long, because being a woman is keeping you protected from heart disease, this is a time to wake up and be proactive about one's health. So that's generally where the preventive side of the menopause research is going, rather than I don't believe there are any clinical trials of long-term estrogen replacement therapy in progress.
Yeah, it's quite I remember this WHI made a huge impact, although there's a lot of criticism about the way it was run and so on, but I think it's still out there and nothing's replaced it at the moment. Does Dr. Shashank Joshi have any questions for our esteemed speaker?
There's also some yes, Dr. Joshi, and there's someone in the chat.
So great talk, Jay, and you make some very interesting insights. We have these modern age drugs called SGLT2 inhibitors, and at the European Society of Cardiology just yesterday late night, we saw some emperor preserved fraction, being presented. So in the era of these big data trials, how do you use these new age agents, in these situations? And do you feel that women post-menopausal are at risk for, heart failure with preserved ejection fraction? That's my second question.
So the second part.
Yeah.
The second part, I'm cautious. I'm giving a cautious yes. At least that was true in the United States for much of the late last century, 20th century. What my colleagues in the heart failure clinic have been finding now is that this old thought that heart failure with preserved ejection fraction all are these little old women is no longer true. you see a lot of high BMI people, women and men, who have preserved ejection fraction. So it is slowly shifting. What one thing you can say is it is a heterogeneous disease. So maybe you can say what is shifting is a different kind of disease that is manifesting in these heavier men and women. But what we have shown with this very early changes in the heart is that we think that after menopause, women are, as compared to where their hearts were trending before menopause, their heart are trending towards HFpEF after menopause. So that part I will say yes, but I think on the overall, men are also starting to show with HFpEF, and not just and also the high BMI group is showing with HFpEF.
Dr. Vajay, there's a very interesting question in the chat. Can you answer that?
The andropause question. So andropause is a much less dramatic event as compared to menopause. So perimenopause at most lasts for a year and a little bit. Whereas change in testosterone levels in men is a much more gradual decline over many, many years. So hypogonadism, I mean, low testosterone levels, we have shown are associated with worse metabolic outcomes and cardiovascular outcomes. So in that sense, I don't think it will be the same thing, because it's a different biology, a completely different range of testosterone levels, different receptor actions. So the biochemistry is going to be different. But if the gradual less lowering of testosterone will result in more adiposity, more metabolic dysmetabolism of glucose, more diabetes, and resultant cardiovascular disease. So in some sense, this long-term andropause will probably be bad, but bad in a different way. Does that make sense?
Thank you, Dr. Vajay. Can I just ask one last question for myself? That is, it looks like it's a diastolic dysfunction in the heart, because, obviously the EF doesn't measure that very well.
Yeah.
Is that correct? Am I correct?
Yeah.
Or it's not as simple as that?
So there is a little bit of a controversy on whether to call it diastolic dysfunction, preserved ejection fraction, at least in the colleagues that I've mostly talked about, seems to be winning rather than diastolic. Some people used to call it diastolic heart failure, and ref used to be called systolic heart failure. I've seen that terminology kind of die out as the idea that it's a diastolic heart failure becomes less useful in describing it. But you can measure diastolic dysfunction. People do measure it in echocardiography, tissue Doppler, and it will show worse diastolic relaxation. So, but it's a stiffer heart, but it does have a higher load on that it is trying to pump against. And the fact of having a higher load to pump against is also going to show up as diastolic dysfunction, rather than primarily the diastole is problematic, so it is not pumping. It is not pumping, so I think the chicken and egg is going towards the other side. So I think that's why HFpEF as a terminology is winning out over diastolic dysfunction.
Thank you.
There's one question which is there in the, so we are live on the Facebook. So there's one question which has come from the viewers, probably a non-medical. They say, like, what is the early stage where, like, a person who's a non-doctor can, feel that there are some issues in the body, and what time does he has to go to the, go for precautions and medicines and like that?
Is this When it comes to heart failure, I think the kind of period that I am studying is long before the patient, before a person is a patient. This is a health. These are the women that I studied are, for all practical purposes, healthy women. And men, the comparison men. So we are saying that roughly the time of menopause for women is already a time for a not an alarm bell to ring in the sense that sit in the ambulance and go to the hospital, but a time for an alarm bell to ring that your heart is already starting to go in the wrong direction. So if you have been less aware of how you can be protective, how you can have a heart healthy lifestyle, this is the time to actually start changing, to incorporate that. So when it comes to my research, I think this is long before a patient has any complaints at all. Because we are studying people where the shape and size of the heart is changing and the patient doesn't even know about it, but they can have a healthy lifestyle and improve their long-term risk.
Thank you very much. Dr. Vajay, thank you very much for the presentation. Now I have actually some time, so I'd like to go through my various colleagues in the different MAs to just get an update on the situation of COVID in their countries. Sarab, can we shall we start the ball rolling, because we don't have much time before the next meeting?
Yeah, so we have 20 minutes. We have exactly 20 minutes, so we can quickly run through the updates from the Medical Association. Let's start.
Maybe we start with Dr. Pillai from India and see whether he can tell us what's happening.
Yeah, thank you. In India, the second wave is still getting prolonged, but then whether it is a prolongation of second wave or the pandemic becoming an epidemic, because the number is contributed by two states, particularly Kerala, with a population of 2.5% of the total population. The contribution to COVID is almost 60%. So it is more like a epidemic now. Most of the other states, things are really under control. The emphasis the government is giving now is for vaccination, and that definitely in one day 1 crore population has been vaccinated. So that is the extent to which the system is working to sort of outweigh the disease. And totally the eligible population, 50% has had one dose, and 15% had both the doses. So that is where we stand as far as vaccination is concerned. And Delta variant is definitely the cause for persistence of the infection, particularly in the state where the maximum number is there, Kerala. Almost 80% of the genomic studies show that it is because of Delta variant, AY1 and AY3. So the COVID appropriate behavior, more emphasis is being given, and people are willing to accept vaccine, and they are on their own coming. And definitely the vaccination process is much more enhanced, and we may achieve the target by the year end. Thank you.
Thank you, Dr. Pillai. I will come to Dr. Prakash next, but can I just ask Dr. Joshi, Shashank Joshi, about the situation as well?
Yeah, I think I agree with Dr. Pillai. 75% of cases are coming from Kerala, but Maharashtra is contributing the second largest. But there is a fear that with the festive season coming up, and Kerala just finished Onam festival, and there are a lot of festive seasons like which are likely to come up in the next couple of weeks. Government of India has put out a red alert to ensure that there is COVID appropriate behavior. Yesterday we broke a record, which is the largest vaccination drive in planet Earth. And I don't think on any given day 10 million doses were given on any part of the world. So I think Indian vaccination program has really picked up, and now it's speaking up. We are also expecting a pediatric wave. So we have one vaccine, which is a DNA vaccine, which is for use in India for children about 12, and the data on 28,000 patients is completed, and that preprint is also available. So overall, we are cautiously optimistic. We feel that the third wave, if appropriate behavior is maintained, is likely to hit somewhere in October, November. I agree with Dr. Pillai that the genomic analysis from Maharashtra and Kerala shows that it is predominantly Delta, though in Mumbai city we are getting a little bit of Kappa as well as a little bit of Delta plus, but none of them is reaching any critical significance. Thank you.
Thank you, Dr. Joshi. Dr. Prakash, you want to tell us what's happening?
Yeah, Dr.
Yes, please.
Yeah, in Nepal now the positivity rate is almost 15 to 20, but we are not in spike, we can say that way, because since the 2-3 weeks the positivity rate is 15 to 20, because generally those who are suspected, those who are in hospital, we are doing the test of that, but in the field we don't have the such a high positivity rate. And luckily the northern part of India, they are in less infection and less casualty. That's why we are also in safe. But interestingly, in Nepal, the vaccination campaigning is going very good, and almost 15 to 17% people are double vaccinated, and 30% people are got the single vaccinated. That's why the hospital facility and others, they don't have the such high load, high pressure. That's why we are giving the much more emphasis in the vaccination program, and luckily we are getting almost all the vaccines from the COVAX facilities, and buying from the China also, and Belarus also giving, Japan also giving, America is also giving, and in the coming month, I think in the September, the India is also told they will give to Nepal the vaccination. That's why I think by the end of 1 month, we almost 40% people will get vaccinated. And by the end of 5 months, we are planning to vaccinate all the people of Nepal. That's what we are doing, and going smoothly. Thank you all.
Thank you, Dr. Prakash. We all need some good news. Can I go to Pakistan next? Prof. Ashraf, do you have something to say to us? I don't see Dr. Salma on the chat.
Thank you very much. In Pakistan, luckily, now people have understood what is happening around and what they have to do. Pakistan is now having the vaccination program, and vaccination is in a very positive way. Although we are suffering from the implementation of SOPs, what the government and the organizations like Pakistan Medical Association, we are asking the people to opt for the SOPs, but unfortunately it is not that much effective. Still we have the celebrations, still we have all the meetings going on. And so from the government side or the public at large, these are the SOPs which has not been followed positively. What news I would like to share over here is that we are now, Pakistan has started and allowed the booster dose, although still it was first and second dose was free of cost, but the government of Pakistan had decided to offer the booster dose, and one has to pay for that. This is what is all over there. In the cities of Pakistan like Karachi, the thickly populated Lahore, we have some sort of about positivity rate around 10. But overall in Pakistan, it is 7.5. We are moving in between 6 to 7. Control.
I think we are losing Prof. Ashraf.
Yeah, thank you very much. I think that I have talked all about. So if you can listen me, so that is all from Pakistan.
Dr. Sajjad, do you have something to tell us, Dr. Sajjad? Dr. Sajjad, are you there?
So it's okay. We can move to another countries now.
Okay, I don't see Dr. Chowdhury, so can we move on to Angelique and Dr. Hussein from South Africa?
Morning to everyone, and thank you for a very informative presentation, Jay. So from us, I will let Dr. Hussein give the stats. We have been a bit more successful this past week in the vaccinations, since we have opened for the 18-year pluses. I think it brings more families now to our vaccination centers. We are busy looking at the possibility of our healthcare workers who had Johnson & Johnson vaccine in February, whether we should give them a booster before December, as we predict our fourth wave to be in December. And we are also looking at regulations in the workplace, where especially in certain areas where you have people working with the public, whether they should become, compulsory vaccination from the employer to the employees, and what are their rights. South Africa's got a very a constitution that everyone's got rights, a very broad constitution. So we are looking at that. And on the political side, we're a bit stable, more stable this week or this past 2 weeks in the Department of Health, although our regulator, our Health Professionals Council of South Africa, is going through a rough patch again. But let's see what happens. All in all, nothing really changed, but I'll give over to Dr. Hussein.
Hussein?
Thank you, Chair. Thank you very much. In South Africa, last 24 hours, we have 12,045 new cases and 367 deaths in last 24 hours. In South Africa, so far, total reported 2.7 million cases, and the recovery is 2.4 million, and the total death till now 80,826, and still 169,000 active cases of COVID. So average, we are doing tests around 58 to 60,000 per day, and our positivity rate is 19.0%. It was 23 last week, so there is improvement here. And in some province like Kerala, in KZN, Durban is almost 30%. And total admission in the hospital last 24 hours, 13,646 new patients. And around the country, the high care admission is 1,900, and ICU is 1,053 cases. Thank you, Chair.
Sorry to hear all these grim statistics, Dr. Hussein. Can I move next to Japan? Marie, are you there?
Yes, thank you very much. Now we are testing about 25,000 people are tested positive, but this rate is still very low. And recently we are doing the mixture of the antibody cocktail therapy, and I heard that it's quite successful, especially for the who is likely to get severe. But we still have mild lockdown all over the country, and we will see what will happen next week. Thank you very much.
Thank you, Marie. Ravi, do you want to tell us what's happening in Malaysia?
Yes. Good morning, Dr. Chong. Thank you, Dr. Wadia, for the lovely talk. But anyway, Malaysia, we are still status quo. We are still seeing more than 20,000 cases. We are seeing record number of deaths. Yesterday, we saw 339 deaths. But the only consolation is about 60% of the adult population have been vaccinated. That is a bit of a consolation. However, the government is still emphasizing on the SOPs like wearing a face mask, maintaining social distance. And we are still in a lockdown. At the moment, what is happening is we are not allowed to conduct meetings. So AGM are all virtual. No physical meetings, and dining in, they have started allowing two to a table, but only those who are fully vaccinated will be allowed to enter the restaurants. And also that at least 80% of the employees of that particular establishment must be fully vaccinated. That means 2 doses. On a lighter note, we have just got our 9th Prime Minister. I think my dear friend in Singapore will be updating himself with our politics here. And we have a new health minister, and we are hoping that these people will be more committed to handling and settling the problem that we're having with the COVID-19. Thank you.
Thank you, Ravi. Dr. Russell from Melbourne, you've got something to update us?
Yeah, well, the story is the same. Australia is dealing with the Delta, and we seem to be split. Half the country is free, and the other half, New South Wales and Victoria, we had, I think, some 70 cases or so, 64 today, and New South Wales are 1,000. And so in the bigger picture, it doesn't look big, but in the other places, as you know, West Australia, the other states have 0. And so there's barriers, no one's opening up, and we have this major discussion going. Vaccination is going on well, and they expect 80% to be there by October, November, when there's some talk of opening up. But they've now started 12 to 15 years. It's been accepted, so they're starting that from next week. They're going to be immunized and so forth. We haven't had any deaths in Victoria, but some deaths are there, not like what it used to be, I think, due to the immunization. So, but still, Victoria, New South Wales, and Australian Capital Territory are under lockdown, and it's also moved to the regional areas in both New South Wales and Victoria. So that's the situation. Not getting better. The Delta seems to take a they're not able to, and there's a argument of whether you want elimination or we want to live with have a suppression, and that half the states want it to be eliminated or below 30. The Doherty Institute has given some a way out program, wanting it to reach 80% and then to open up borders and so forth. So that's the program. Whether that will happen by the end of the year, where they plan to open the country up after that. So that's the situation here.
Thank you, Dr. Russell. Very challenging situation.
Yes, and because we had hardly anything for the last so many months, and suddenly this has happened. Yeah.
Sorry to hear that. Dr. Benito from Philippines, you have something to update us, Dr. Benito?
Dr. Benito, you're on mute. Please unmute yourself. Yeah. Oh, you're mute again.
Our updates is ongoing every 4 o'clock in the afternoon. That's why I will give you the update yesterday. As of yesterday, August 27, we have a total number of positive cases for that day, 17,447. The highest was 18,000 last week. And we have a total number of deaths yesterday of 113, with a total number of positive cases since last year of 1.7 million, and total number of deaths is 1.7%, 32,941 as of yesterday. That's all.
Thank you, Dr. Benito. And just to update everyone, Singapore, we've hit about 79% 2 doses of vaccination, 79% of the population, 83% have received 1 dose. So we're still trying to close the gap desperately. And Delta is proving to be very, very difficult to control in Singapore. We have 100 over cases a day now, still, despite all our intensive measures. Very, very difficult situation. And again, I think the debate is going on globally, whether zero tolerance versus living with it endemic. You know, that is always the issue. So I think come to the end of the.
No. I'm hello.
Hey, Alvin, sorry.
Can you, yeah. Our best friend.
Sorry.
Yeah. So even though the travel bubble is now burst, we are still liaising each other about this pandemic trouble. Yes, and well, in Hong Kong, we're still lagging behind Singapore a lot. We only have about 60% of our population with the first dose, less than 60%, and only about 40% with the second dose. And so we still have a glim hope that we could have 70% of vaccination in the population at the end of September, okay? But of course, the fifth wave in Hong Kong had not yet arrived, thank God. So we still have 12,000 cases confirmed so far with 212 deaths. 212 deaths all so far. But then I think we still will have to persist in the strategy of zero tolerance because we have only 20%, less than 20% of our elderly being vaccinated. So it's dangerous for them if we open up. And even for the young age group, less than 29 years of age group is only about 30%. So mainly it's the middle age group that had the very high vaccination percentage. So one of our professors, he said that he would expect 97% of our population being vaccinated if we really want to have a meaningful herd immunity for Hong Kong, because the Delta variant is so dangerous. So, so that's why we still have to keep our zero tolerance approach now. But then we had encouraged more dutiful, that is not mandatory vaccination. But for those high-risk professions, we would expect, quote unquote, like a mandatory vaccination, but it's not mandatory. That is the other option of vaccination is like change to another job, change to another position, or you need to have a weekly testing. That is the intranasal and nasopharyngeal PCR. And then we would have to ask the, say, airport staff, teachers, hotel staff, that is the quarantine hotel staff, elderly center staff, all the health workers, they would need to have vaccinations if they really want to continue with their job and no need to have the weekly testing. So I think with such an approach, of course, there are objection and opposition voices in our society. But then I think the Hong Kong Medical Association, we had encouraged people in these professions to have dutiful vaccination. That is, we are mindful of the needs of our patients, of our clients, of our students, etc. And at least in the hospital authority, that is the public hospital sector, 98% of the doctors were already vaccinated, and that is a very good example. And nurses only had 70% of the nurses had been vaccinated, and the other general staff in the hospital authority also only got about 70%. And we hope that the healthcare workers could really have the duty to have the vaccination. But in private, there's no control at all, no requirement at all. So in the private sector is really not satisfactory, I would think. At least we need to have the data, but then it's all free. So I don't know how many percent of our private health workers had got the vaccination. But anyway, I think and international news is, of course, Nicole Kidman, who came to Hong Kong being exempted of the quarantine. But then it kicked up a lot of fuss. And our Minister of Health had been bombarded all around it. But anyway, I think exemption at the border is really dangerous. Just yesterday, we had 15 cases of imported Delta. 13 were from an Indonesian ship. And luckily, they were not exempted of testing and quarantine. And the government had now been tracing whether they are using fake reports, fake vaccine passports, etc. I mean, that is a real problem, because if we open up our border, we cannot control if anybody could have got hold of some fake certificates. And then that would be a problem if we have the exemption of we had opened up the border. So that's our dilemma.
Thank you.
Thank you very much.
Thank you, Dr. Alvin.
Thank you. Sorry to have missed you out. But we all have the CMAAO meeting on the 2nd of September. So I look forward to seeing everybody at our CMAAO meeting, 2nd and 3rd of September.
So thank you, everyone. We will end this session. We have another session waiting for us. And this was the 73rd session. We will close the session. Thank you, everyone, for joining in. Thank you, our speaker from Johns Hopkins University, for joining in for the wonderful session.